Hello, I'm Dr. Marla Dubinsky. I'm the Chief of Pediatric Gastroenterology, Hepatology, and Nutrition at the Icahn School of Medicine, Mount Sinai, New York, as well as the co-director of the Susan and Leonard Feinstein Inflammatory Bowel Disease Clinical Center. I am bringing you updates from the key insights and great debates in inflammatory bowel disease meeting that took place in San Francisco. And I'm joined by Dr. Joel Roche here, where we can discuss some of the highlights of the meeting that took place.
Well, Marla, it was a jam-packed agenda, and I'd love to get some of your insights about, let's just first start with the morning session. It was a very nice, well-tied-together theme of a holistic, full view of taking care of the IBD patient from a 360 perspective. We heard from Uma Mahadevan right here from San Francisco talking about the care of the pregnant patient. Lori Kiefer from your institution spoke about the psychosocial considerations of the IBD patient. And Caroline Wong talked about health maintenance in the IBD patient. What were the main takeaways for you from those excellent sessions?
So I think part of our discussion should absolutely kind of focus on those key insights that are clinically very practical. So I'm going to start with pregnancy and IBD. That's a very topic near and dear to my heart. I think what Uma did a great job of is really kind of telling us what are the practicalities of managing a woman who's either considering to be pregnant or a woman who's pregnant. I think there's a couple of key things we need to remember when managing a woman who's pregnant per se. Would be really about one of the hot topics is the safety of therapies during pregnancy. A lot of discussion was surrounding, would you choose a biologic based on a woman who wants to get pregnant? Would you switch patients to a therapy that may or may not cross the placenta? So I'm going to kind of give some summary statements from which I think, not to speak for her, but some of the considerations she had displayed. Take anti-TNF therapies for just as the highlight of the discussion. We know that of adalimumab, infliximab, or certolizumab, we know that certolizumab is the one anti-TNF therapy that does not cross in the third trimester of pregnancy. And the reason why that's relevant is that there was historically concern that if a baby is exposed to an anti-TNF therapy, that may increase the risk of infection. What she showed us, an update on the PIANO registry, which is a big observational prospective cohort study, we have shown that actually the risk of infection is not increased in women exposed to biologics, despite being exposed in the third trimester to the adalimumab or infliximab. Well, we did know what differentiates that group is that because we tell our own IBD patients if they're exposed to biologics at any point, not during pregnancy, at any time, they're not allowed to get live vaccines, right? We talk about you need to delay it, or you shouldn't be getting live vaccines when you're on our therapies. When you're on certolizumab, babies born to mothers who were exposed to certolizumab during pregnancy, the rotavirus vaccine, which is a live vaccine, would be okay. It's given before essentially 15 weeks of age. And so we're saying to them that's the one thing that differentiates really certolizumab exposure from adalimumab and infliximab is that in the babies that were born to moms on adalimumab and infliximab, we're asking them to not get the rotavirus vaccine, and that when they're a year of age and they can get varicella and MMR, which are both live vaccines, that's not a problem. So really that was a big question that we get asked, and in my preconception planning clinic, that's like number one on the list of what they want to talk about is, can I continue my therapies? What about biologic exposure in the third trimester? Because their physician had talked to them about it. She introduced a list of when she would stop therapies, and she did note that in the third trimester she's not stopping any therapies. And she's not stopping certolizumab and allowing women continue that in the third trimester. In women who are on adalimumab, she was stopping therapy around 36, 38. It was variable. Some even stop at 34. I think it depends on how the mom is feeling and also how sick the mom was going into pregnancy. And infliximab, we're both on the same page that we're stopping drug around 30 weeks of gestation, so that immediately upon delivery they're due for their next infusion. At Sinai, for example, before moms actually leave, they're getting their infliximab infusion just after delivery. So we're timing it as such because our high-risk OBs are kind of used to actually, they'll order the Remicade knowing that before the woman leaves the building after delivery. So I think that was probably one of the most important take-homes for me is just the idea of the timing of exposure and the risks to the baby and the risk of infection. There was this controversy about whether to continue thiopurines, because there was a publication from Amsterdam, the Netherlands, that suggested that thiopurines do cross. Again, the drug levels in the mom correlate with the drug level of the cord and of the serum of the baby. So there was this concept that maybe we should be stopping thiopurines in the third trimester if they were with combination therapy. That's an easier decision, but with monotherapy thiopurine, I think the jury's out, and there's probably more data that needs to come from it. So that's what I got kind of from the pregnancy planning piece and what to think about as it relates. And breastfeeding, we agree, is safe on all of our therapies, including thiopurines and all the biologic therapies. The tie-in, I'm going to talk first about health maintenance, because I think health maintenance kind of is a natural progression, is that this concept of overarching self-management and self-efficacy, which we'll get into Lori's discussion on, also the psychosocial component. But before we get to that, I want to highlight that Carolyn was very clear that a way to keep people in remission is not just to think about therapy, but it's also about thinking about prevention strategies and reminding patients about simple things like annual skin checks. You know, when we talk about safety of therapies, we'll talk a little bit about skin cancer, the importance of pap smears in women who are exposed to biologics or immunomodulators, and even women without IBD. There was a study by Susie Kane suggesting that IBD alone, maybe due to the inflammation or immune system, you're at increased risk of having abnormal pap smears. Having your colon cancer screening strategies in individuals who have colon involvement. Being able to ensure your vaccines are up to date, thinking about separating out live vaccines from non-live vaccines. I think there's a real interest and push to really making sure that we're very clear that hepatitis B vaccination is important. I think for me, I view hepatitis B vaccination status, to know the status of the hepatitis B immunity, is because even someone who's on a mesalamine, you never know if they're going to need a biologic. You just never know. So for me, it's about being prepared. So hepatitis B status, at least knowing about, is important. Whether we revaccinate is up to the decision of the provider and the patient. And if a patient likes to travel, or if they're in the healthcare industry, typically they are getting their Hep B revaccinated so that they could have immunity. Varicella status, knowing the varicella status for sure up front is important, because we can't get, we're not giving for example, the varicella vaccine in the pediatric age group. We're avoiding it in the face of anyone who's on biologics or immunomodulators or high-dose steroids. So if I had a window of opportunity of about 4 weeks, because we tend to delay the start of immunosuppression or biologics by about 4 weeks, and that's even being generous. Some of our ID folks would like you to wait 8 to 12 weeks before you're giving an immune modulator to someone who's gotten a live vaccine. And then the Pneumovax and the Prevnar 13. There's even commercials now for Prevnar 13, and that anyone who's immunocompromised above the age of 6, and for sure in individuals above the age of 65, that patients should be vaccinated against pneumococcal infection. And we know the Pneumovax, and patients should be getting it every 5 years. But now with the Prevnar 13, just to be a little bit of a key insight there, is that if you give the Pneumovax, you have to wait a year before you can give the Prevnar 13. So the key is to give the Prevnar 13 first, because there's only a minimum 8-week delay before you can give the Pneumovax. So I think that's an important distinction that a lot of people get confused. And even when I give a written report to a physician's office, they may in error give the Pneumovax first, so they can't get the Prevnar 13 for a year. So I think that was a key insight that I'll remember to continue to reinforce to patients. And I think the other question is about zoster. We get a lot of questions about, our advancing age group and the increasing risk of shingles, or the increasing incidence that we're seeing in patients, both on biologics, but particularly on immunomodulators. And the guidelines right now is such that the zoster vaccine is completely contraindicated in patients on biologics, most specifically anti-TNF, because when the guidelines were made, they weren't talking about vedolizumab, for example, and I'll get to my thoughts about that in a second, but it was mainly focused on anti-TNF. They are saying that if you're on steroids less than 20 milligrams, Doses of methotrexate, which I believe are within the dose of what we would use because it's based on a meter square dosing or milligram per kilogram dosing, and Imuran or the thiopurines, as long as they're on less than 3 milligram per kilogram of Imuran or 1.5 milligram per kilogram of 6MP, you can use the zoster vaccine. And that's a lot of our patients. So right now the question is if advancing age is moving earlier and earlier, but in theory, let's talk about 60 or above, and we have patients who are at risk of shingles, and the shingles vaccine is for people who are above the age of 50, do we need to look at the data that shows that zoster has actually been intentionally given to a group of patients who are on anti-TNF, and it was actually shown that people were not getting either acute varicella infection, so maybe it is safe, but yet still contraindicated per the CDC. But maybe will we be able to use zoster in individuals who are on vedolizumab who are of advancing age, and maybe that is the right combination where maybe, because it's a gut-targeted therapy, that a live vaccine is possible. And that still remains to be studied and looked at, but I think we need to look at unintentional use of zoster in that population. I think that would be a very interesting topic to look at. So we talked about, preconception and pregnancy and therapies used in pregnancy, and then the concept of health maintenance. And you can't not talk about health maintenance without talking about self-efficacy and self-management and the role of being a resilient patient and the importance of having the behavioral psychology component of IBD well taken care of, and to remember that 30% of people with IBD, particularly females, have irritable bowel on top of their IBD, and we've got patients who have normal mucosal healing, deep remission, but continue to have symptoms that plague them every day. And so I think forgetting about the importance of the psychosocial impact of the disease would be missing a third to possibly half of our patients who continue to have symptoms despite being well managed and what we consider to be in deep remission. So I think Lori taught us a lot about her target, which is treating to target, which is to be self-effective and self-manage, and to figure out what are the underlying issues that are giving patients symptoms despite us seeing complete what we know is our target, which is potentially mucosal healing. So that's what I took away from Lori really telling us, that we need to remember that there are ways, such as hypnotherapy she talked about, that hypnotherapy, not that she proposed that hypnotherapy changes the actual inflammatory cascade, but that potentially hypnotherapy may help them be more self-effective, come to the doctors more, talk about symptoms more. It's hard to say.
Certainly a jam-packed morning.
Yeah.
A lot of good pearls to take home. After the break, we came back and heard from Fernando Vallejos, also here from San Francisco, about one of his favorite topics, the post-operative patient, and be interested in your thoughts of how to best optimize outcomes in our patients who've had surgery. He also then talked about managing the patient who's had a malignancy and with his concern about previous malignancy and all the new medications that we keep fortunately having for our patients, how to best optimize that. And you educated us about the whole concepts of treating to target. We'd love some take-homes on that,
Sure.
of how to optimize our therapies.
So I think the post-op story still remains a little bit unknown, I'll be honest with you. I think there has been no optimal algorithm. I think two key points about post-op is that we have two good studies. We have the PREVENT study that, although did not meet their primary endpoint, which was due to a primary outcome measure and definition that isn't really quite clinically practical, the study didn't meet its p-value endpoint, which means it was a negative study. But when you look at the meat of what we're really looking for, which is whether or not infliximab in this PREVENT study is better than placebo at preventing endoscopic recurrence, meaning purely looking at what we believe to be important, especially those with quite significant ulcerations, meaning what we call Rutgers 3 or 4, which is using the Rutgers post-op scale. There was a clear p-value and numerical difference between drug and placebo. So the PREVENT study, albeit negative in its primary outcome, isn't going to change practice. We still believe that the use of anti-TNF is important to prevent post-op endoscopic, which will translate into clinical recurrence. The PREVENT study was only a 2-year study. We know that endoscopy precludes clinical, so we still believe that it's important to prevent endoscopic recurrence. The POCR study, which is using adalimumab, which was published by Michael Camm's group from Australia, showed a little bit of a different take, still showing that post-op maintenance is important and it prevents endoscopic recurrence, but in their group they actually suggested that patients who were at high risk of recurrence, that there was definitely an advantage of using a post-op anti-TNF therapy. But what they showed is that it could be that not everyone needs treatment right away, and that patients who started, for example, adalimumab at 6 months didn't do that much different than patients who started adalimumab right after surgery. So maybe, I'm not suggesting it 100% so because we need more information on it, that maybe it could be that that 6-month endoscopy may be the deciding factor of when a patient needs therapy. I think we all believe if someone came in with perforating Crohn's disease who was on an anti-TNF, probably needs to continue on some kind of biologic therapy. I'm not saying it's the anti-TNF per se, maybe it's vedolizumab, or maybe it's the new drug. If ustekinumab comes out, maybe we'll be switching to different pathways. But in general, I think we're learning a lot that patients probably who are high risk and be able to risk stratify need some kind of therapeutic intervention post-op. If we talk about the risk of therapy, I want to focus a little bit on both skin cancer and lymphoma, because I think those are probably the most important things we think about in terms of what plagues our patients and what plagues us when we're prescribing biologics and immunomodulators. I think the key insights that came out of Fernando's talk was that skin cancer, meaning non-melanomatous skin cancer, is increased in patients on thiopurines. Therefore, the annual skin check going into the health maintenance that Carolyn talked about is important. He also described that melanoma looks to be potentially not increased with thiopurines, but more so with anti-TNF therapy. And there's also data to suggest that melanoma may be increased in IBD alone. So I think the melanoma story needs to be kind of fleshed out a little bit better, but we've got a lot of data on non-melanoma skin cancer and thiopurines, and I think that was what message he was trying to get across. The lymphoma story is completely different. The same group that told us that non-melanoma skin cancer is elevated using the SASAM database showed us that lymphoma is increased in patients on thiopurines. Granted, the greatest risk were in males that were above 65. That was using B-cell, not the hepatosplenic T-cell lymphoma, but looking at the other forms of non-Hodgkin's lymphoma. He also suggested that there was a huge tie-in to EBV and lymphoma. I just want to give you a little bit of an update on pediatric side, because we talk a lot about hepatosplenic T-cell lymphoma in the young age group and sort of non-Hodgkin's lymphoma in the advancing age group, and really separated on age. At ECHO, just yesterday, the DEVELOP registry data was published. This is a pediatric post-marketing commitment registry that is overseen by a steering committee, but sponsored by Janssen after infliximab was approved for pediatrics, especially given the concerns about hepatosplenic T-cell lymphoma. We have 5,000 children that have been followed for 25,000 patient years of follow-up to date. The goal is 20 years of follow-up, so 1 million patient years of follow-up. So we're about 5 years in, and so far the data, we have 2,500 patients that were exposed to anti-TNF and 2,500 children who are not exposed to anti-TNF. Most commonly, thiopurines were the non-TNF exposed group that we were looking at, particularly as it relates to outcomes of malignancy. And what we were able to show is that there was a definitive relationship, again, small numbers, so it wasn't per se p-value powered to show, but there was a definitive trend to show that all cases of HLH, or hemophagocytic lymphohistiocytosis, HLH is so much easier to say, all cases were tied to thiopurine and EBV exposure. And to date, the malignancies that we have, based on the data cut of June 30th, 2015, all cases of malignancy, both skin cancers and lymphomas and or solid tumor cancers, have been tied to thiopurine use, whether in combination with TNF or alone. I think there's long-term data to be looked at even more, and I think we're just starting to see a trend even in pediatrics that there's a tie-in to the use of thiopurine. So I think we need more data, but I think that, as we talked about extensively at this meeting, there's definitively a movement, particularly in the older age group, however you define advancing age, and in the younger age group, that we should probably be looking for alternatives to treatment as opposed to using thiopurines in the future. And just one quick note on treat to target, I think what I was trying to come across as a key insight for that is that you can't just let your patient return when they're not feeling well. The key to keeping a patient well for the long term and moving the needle on preventing complications and surgeries in the realm of IBD, since this is a chronic disease state, is to keep someone in very tight control, which is find your target, which I think we're moving towards mucosal healing. Find it. Once you see it, follow it closely with non-invasive biomarkers such as CRP or calprotectin or whatever biomarker you feel confident with. Follow it routinely. Develop a routine and a conversation for your patient to say, I'm due for my biomarker to tell me that I'm actually want to see if I'm still in remission. And engage the patient in the conversation that in other disease states where they have targeted their outcome, it has been tied to even survival and improving the legacy when you compare it to other diseases that have actually been able to keep their patients in tight control.
Well, thank you. That was a lot of information that's very important and practical to the practitioner who cares for the IBD patient.
Thank you. Thank you very much for watching the key insights from the Great Debates meeting in inflammatory bowel disease.